In 2010, Blue Cross entered a collaboration with a company called MedMind, which is now called CareFusion, that provides software that will monitor hospitals' databases for potential infections. This is a very important tool that allows those hospitals to go identify patients who potentially could have some sort of a hospital-acquired infection and hopefully intervene before that infection gets severe, and also allows them to look at their processes and improve the odds that patients will never get the hospital-acquired infection.
Just how serious is the problem of hospital-acquired infections, and how widespread is it?
These are fairly common. They're really a large cost driver in terms of both human lives. There are many deaths in the United States every year from hospital-acquired conditions, and specifically the infections. When patients have devices in them like central lines and IVs and catheters, these really do set up the patient for infections. And working on protocols to reduce those chances of infections is very important. It's going to save lives and lots of money and lots of hospital bed days.
Welcome again to our third Louisiana Hospital Quality Initiative Best Practice event. This has been certainly much of a success. We've had the pleasure of our participating hospitals over the last 3 years now, and we're hoping to continue this partnership. Of course, today we have an exciting agenda, as always, with great national speakers, recognized speakers.
Infections are a huge part of quality issues that are going on in hospitals right now. Some of my first tasks have been around looking at our hospital quality incentive programs as well. I've kind of chatted with a few of you about some of that as it comes out forward. There will be some incentives on infection control as well, but we're going to develop that as we go forward, and I hope to maybe have a spring kickoff in a format similar to this to explain what some of those initiatives are.
You've got to get to the surgeons and to the frontline people. You've got to talk to them. It's not through committees or emails. You've got to really take that time to crunch the data, put the numbers together, and get in front of them. And I could see at first, they're like, what's this nurse going to tell us? They didn't even know we owned them, that UHS even owned George Washington. So it was an eye-opener for them, and they really, at the end, the residents especially were asking me so many questions. I mean, hands were going up constantly, because they don't get this. And the key thing about CLABSIs is that we stick something in their skin. We break the skin, and then we're going to leave this thing sitting there for a period of time. So, of course, organisms that are on the skin are going to creep and crawl up that catheter. What happens is a small amount of it, gets on the catheter, and usually we have the bacteria adhere to the polyurethane or the silicone, and then within seconds, they multiply every 20 minutes. So within seconds, you start to get the protein and platelets and white blood cells because you've had a trauma to the skin. So they all stop migrating down into the wound bed, and they kind of produce this little sheath, a fibrin sheath, and then eventually thrombus formation occurs on the catheter, and that's a breeding ground for organisms. We're in the field of infection prevention are getting more and more demands on our time to be able to do surveillance and actually, kind of hunt down all these infections. And so, unfortunately, we haven't been able to have the increase in staffing levels to do that. So a lot of their time is being spent at the desk. And it's like a command center looking for all of these central line infections and people with ventilators getting infected and surgical site infections. So the prevention part of it, which is why they changed our title from infection control nurses to infection preventionists, is to be out on the floors in the intensive care unit, working in the operating room, and actually working very closely with the microbiology lab. So that's a challenge for us right now, and that's being addressed by some of the institutions by increasing the staffing levels with them. The other problem is the host. The patients that come in the hospital now, two of the biggest and most serious complications that we deal with are related to obesity and diabetes. So we have a nationwide outbreak in this whole country of obesity, which goes along with diabetes. And those two really increase the risk of infection for patients. So from the public point of view, that's one of the things that we can really work on from a prevention point of view, is starting to look at nutrition and look at prevention measures there, because it really does adversely affect them in the hospital. They're more difficult to move around in beds, they're more difficult to do surgery on, and their immune system is compromised. So we have done a lot of really good prevention measures, so the rates have gone down, which is really kind of encouraging. That if you look at the Center for Disease Control, their national health safety network has shown pretty good significant reductions in some hospitals as far as some of these central line infections especially. So that's the hope that we're going to be able to get this under control. We need the help from the public as well. We need them to actually get into better, more healthier states in the prevention arm of it, and not rely on us just treating disease, but prevent disease.
What's your assessment of what's happening here in Louisiana with this initiative?
Oh, this initiative is great. I mean, they're bringing together some of the top speakers that are going to address some of the really more serious healthcare-acquired infections. I'll be talking about the central line infections, which have a very high mortality and morbidity rate, and a lot of the control measures that can pull those under control. So this kind of a agenda is what we need. We need much more education of the public, as well as all of the healthcare workers, and how they can all work together.
My father in the hospital not that long ago, and insistence on good hand hygiene by the staff. That is a right that you can ask the staff to be sure to wash their hands before they adjust an IV or things like that. Other than that, when you don't need a catheter or an IV, it's best to go ahead and ask if that can be removed as soon as you don't need that. And so those are probably the two bigger things on infections that I would probably advocate for patients.
We've done many things to reduce infections, whether working on catheter-associated urinary tract infections, only putting catheters in when they're absolutely necessary, removing them whenever we no longer need them. If you don't have a device in, you can't get an infection from it. And working on central line-associated bloodstream infections, trying to reduce the risk of an infection related to those, putting all kinds of safety features into whenever you have surgery, like taking CHG showers the night before, using sage cloths, treating people who are colonized with MRSA so that they have a less chance of getting an infection, changing our antibiotics to make them more weight-based, given the right dose, the right antibiotic for the right amount of time, therefore reducing that patient from having a risk of having an infection related to a surgical complication.
Have you seen results?
Oh, we've seen drastic results. Since we've put these measures into place, we call them bundles. The bundle to try to reduce that risk of infection to that patient, whether it being like for a catheter-associated tract infection would be that you're putting you're keeping the bag below the level of the bladder, you're putting a dependent loop. There's all kinds of little things, little details that we put into place to try to reduce that risk to that patient, and they're very effective.
Our hospital is working with the MedMind software to target patients to reduce the number of inpatient infections, nosocomial infections, catheter-related infections, and working with a very tight program to reduce their length of stay and their days of therapy or unneeded therapy.
What kind of results have you seen?
We've had wonderful results. We have gone from the 4th quartile in a premier database to the 1st quartile in the database. And so we're very, very pleased with that.
What's your assessment of the Louisiana Hospital Quality Initiative?
It's necessary. It is a great program that really is necessary to bring all these parties together to find the solutions to the healthcare problems we face in the state.
I am very encouraged to have all my colleagues from the state here, that we can share what we've done that works. So it gives you, it makes you all excited that you might find something that you can do that's a little bit different, that might improve the quality of our patients and the safety that we're providing in the hospitals.
It's a good network of people, and everyone is on the same page as far as trying to work to improve our healthcare system.
The hospital systems and Blue Cross, we are working together to reduce the chances of harm that comes to patients in our hospitals. And we are making strides, we're making smart investments into technologies that really extend our ability to detect those infections early.
If people have questions like more information, what should they do?
They can always go to a really good source like the CDC website. They can also, visit the Blue Cross and Blue Shield website as well to get some information. CDC is probably the standard place to go that has relevant, patient-friendly documents regarding certain infections.